Welcome back to the deep dive. Really glad you could join us.
Good to be here.
So today we're tackling something a bit different. We've got this stack of revision notes, you know the kind.
Yep, dense. Lots of facts.
Exactly. And our goal is to, well, unpack them. Pull out the really essential stuff, the high-yield info you absolutely need.
Make it make sense. Quickly.
Precisely. Think of it like a revision shortcut.
Yeah.
Today's focus is Friedreich's ataxia.
Right. A complex topic. We'll aim to distill everything from the definition right through to management and prognosis, all based on these notes.
Perfect. Let's lay the groundwork then. What exactly is Friedreich's ataxia?
Okay, so at its core, it's described here as a progressive hereditary neurodegenerative disorder.
Let's break that down. Progressive.
It means it gets worse over time. It doesn't stay static.
Hereditary.
Runs in families, it's genetic.
And neurodegenerative.
That points to the primary target, the nervous system. It involves the loss of nerve cells, nerve function.
Okay. And what are the kind of hallmark characteristics mentioned?
The notes highlight a few key things. Muscle weakness is one. A significant loss of coordination, that's the ataxia part.
Right, the name.
Exactly. And also impaired reflexes. Often they're reduced or, completely absent.
You mentioned hereditary. Can we dig into the genetics a bit? What's the story there?
Yeah, this is crucial. The notes classified it as an autosomal recessive trinucleotide repeat disorder.
Oh, okay. Bit of a mouthful.
It is. Let's unpack that. Autosomal recessive means you need to inherit a faulty copy of the gene from both parents to actually have the condition.
Okay, one from each.
Right, and trinucleotide repeat. That refers to a specific sequence of 3 DNA letters, in this case, GAA, which is repeated over and over again, way more times than it should be.
And this faulty repeat is in a specific gene.
Yes, it's a mutation within the frataxin gene. The notes specify FXNgene on chromosome 9.
So too many GAA repeats in the FXNgene.
Essentially, yes.
Yeah.
And these excessive repeats basically shut down the gene, leading to much less frataxinprotein being made.
Is there anything unique noted about this repeat disorder compared to others? Like Huntington's, for instance.
Yes, that's a really important point highlighted here. Unlike some other repeat disorders, Friedreich's ataxia doesn't show anticipation,
Anticipation being?
where the condition tends to get more severe or start earlier as it's passed down through generations.
Yeah.
That typically doesn't happen here.
Good distinction to remember. And how common is it, generally speaking?
Well, the notes state it's the most common early-onset hereditary ataxia. So among those inherited coordination problems starting young, this is the one seen most often.
Okay, let's connect this frataxin protein, or lack thereof, to the symptoms. What does frataxin normally do?
Its main job is inside the mitochondria.
The cell's powerhouses.
Exactly. Frataxin is involved in handling iron correctly within the cell and making sure those mitochondria function properly, generating energy.
So if you don't have enough frataxin, then what happens?
Well, the mitochondria start to malfunction. The notes mention this leads to problems like iron building up toxically inside the cell and increased oxidative stress.
Oxidative stress, like cellular rust.
That's a good analogy, yeah. It's damaging. And this damage hits energy-hungry cells, the hardest nerve cells, heart muscle cells.
Ah, okay. And that's the direct link to the symptoms like ataxia.
Absolutely. The notes explicitly connect the dots. They say the early and severe impact on sensory neurons, specifically the ones involved in proprioception, telling your brain where your limbs are, leads directly to that characteristic ataxia.
So the nerve damage flows right from that mitochondrial problem.
Precisely. It's that fundamental issue with frataxin deficiency, causing the mitochondrial dysfunction and oxidative damage.
Got it. So who's most at risk then?
The main risk factor is inheritance, having parents who are both carriers of that mutated FXN gene.
And does it affect one sex more than the other?
No, the notes say males and females are affected equally.
Any other factors? Ethnicity?
It's mentioned as being more common in individuals of European descent.
Okay, so just to recap the mechanism simply. Faulty gene, frataxin, messed up mitochondria, and iron cell damage, especially nerves and heart.
That's a really solid summary of the core pathophysiology described here. An energy and iron issue causing system-wide trouble.
Right. Now, zooming out, how widespread is this condition? I think the notes had some UK-specific numbers.
They did. The estimated prevalence in the UK is around 1 in 30,000 individuals.
Which makes it?
One of the most common inherited ataxias in the UK, yeah. Affecting, they estimate, about 2,500 people there.
And the typical age it shows up?
Usually between 10 and 15 years old, so firmly an early onset condition in most cases.
Let's paint the clinical picture then. What would a patient actually experience? What are the signs?
You're looking at progressive neurological symptoms. They creep up and worsen over time.
Like?
Well, the big one is progressive ataxia, the difficulty with balance, coordination, walking. Then there's dysarthria.
Speech problem.
Yeah, slurred or difficult speech. Also, reduced proprioception and vibration sense. So losing that sense of where your limbs are without looking and not feeling vibrations well.
And weakness.
Yes, muscle weakness, noted especially in the limbs.
Is it purely neurological, or do other systems get involved?
Oh, definitely other systems. The notes really emphasize associated conditions. Two big ones: cardiomyopathy and disease of the heart muscle,
Okay.
and diabetes mellitus.
Right. What about specific things a doctor might find on examination? Neurological signs.
Commonly absent ankle reflexes or ankle jerks, and often an abnormal Babinski sign, the toes go up instead of down, the extensor plantar response.
Mm-hmm.
You'll see cerebellar ataxia that points to damage in the cerebellum, the coordination center.
Mm-hmm.
Optic atrophy, as mentioned, damage to the optic nerve affecting vision. And signs of spinocerebellar track degeneration problems in the spinal cord pathways affecting coordination too.
That heart condition, the cardiomyopathy, seemed like a really major point in the notes.
It is hugely important. The source states hypertrophic obstructive cardiomyopathy, a specific type where the heart muscle thickens occurs in, get this, about 90% of cases.
90%? Wow.
Yeah. And it's stressed as being a very common cause of death. That's definitely a high yield point if you're revising.
Definitely. And the diabetes, how common is that?
Present in about 10 to 20% of individuals with Friedreich's.
Any other physical signs you might notice?
The notes list a high-arched palate. Also, skeletal issues are common things like scoliosis, the curved spine, and pes cavus, which is high-arched feet.
And can those appear early?
Yes. Interestingly, the notes mention that scoliosis or pes cavus might even show up before the more obvious neurological symptoms like the unsteady gait begin.
So the first sign isn't always trouble walking.
Usually it is. Gait unsteadiness is typical, but yeah, you might see those skeletal changes first sometimes.
And is onset always in childhood adolescence?
Mostly, yes. But the notes do mention late onset cases. Sometimes milder symptoms can appear later, even up to age 50.
Okay. So if someone, say a teenager, presents with progressive ataxia, how do doctors figure out it's definitely Friedreich's and not something else? What are the differentials?
That's a big question because lots of things can cause progressive ataxia starting young.
Yeah.
You have to think about other inherited ataxias. First, the spinocerebellar ataxias, for example.
Mm-hmm.
Then there are acquired causes. Could it be something like multiple sclerosis presenting unusually? Or even, vitamin deficiencies?
Any specific deficiency highlighted?
Yes, vitamin E deficiency. It's crucial to check for this because it can look very similar to Friedreich's ataxia symptom-wise, but unlike FA, it's actually treatable with supplements.
So that's a must check.
Absolutely.
Absolutely.
You also have to consider toxic causes, metabolic problems, immune diseases, even tumors or structural issues in the brain or spine. It's broad.
Are there any clues mentioned that might point away from Friedreich's ataxia? Things that make it less likely?
Yeah, the notes offer some pointers. For instance, if imaging shows significant cerebellar atrophy very early on, or if there's a learning disability alongside the ataxia, or perhaps if the sensory nerve signals, SNP potentials, are actually normal, these might suggest looking elsewhere.
Because sensory loss is typical in FA.
Right. Absent or reduced sensory action potentials are pretty characteristic. It's also noted that while scoliosis and cardiomyopathy are common in FA, if they are the only major findings very early, you'd still consider other possibilities too before landing on FA. It sounds like a complex diagnostic path.
Yeah, they even mention a specific diagnostic algorithm exists for these kinds of chronic progressive ataxias in childhood. Shows it needs a structured approach.
So once Friedreich's is suspected, how is it confirmed? What investigations are key?
The definitive test, the gold standard according to these notes, is genetic testing.
Makes sense. Looking for that GAA repeat expansion in the FXNgene.
Exactly. That nails the diagnosis.
And what other tests are used to sort of assess the damage or related problems?
Quite a few. Electromyography, EMG, often with nerve conduction studies to assess nerve and muscle function.
Okay.
Cardiac checks are vital, so ECGs and echocardiograms, looking for that cardiomyopathy. And MRI scans brain and spinal cord to look for structural changes like atrophy, especially noted in the cervical spinal cord area. Are there specific findings on those tests that scream Friedreich's?
Well, on the nerve conduction studies, a key finding is often those absent or severely reduced sensory nerve action potentials, even if motor nerve speeds are relatively okay.
Right, that sensory loss again.
Exactly. The ECG might show signs of the heart-thickening ventricular hypertrophy or specific T-wave changes. The echo directly visualizes that thickened heart muscle. And the MRI can show atrophy, particularly in the spinal cord.
Other tests mentioned.
Blood tests are important too, basic checks, glucose for diabetes, and crucially, testing vitamin E levels to rule out that deficiency we talked about. They also mention things like auditory and visual evoked potentials to check specific sensory pathways.
And given the genetic basis, is counseling part of the process?
Oh, absolutely. Genetic counseling is highlighted as crucial, offering testing for family members, carrier testing, and discussing options like prenatal diagnosis.
Okay, so the diagnosis is confirmed. What's the plan then? How is Friedreich's ataxia managed? Is there a cure?
That's the tough part. The notes are clear. There is currently no cure. So management is all about controlling the symptoms and trying to manage or prevent the complications.
How do they approach that?
It absolutely requires a multidisciplinary team. You need neurologists, geneticists, physiotherapists, speech and language therapists, occupational therapists, social workers, all coordinating care.
A whole team effort.
Definitely. And regular checkups are key. Monitoring everything, neurological progression, heart function, any scoliosis, checking blood sugar for diabetes.
What about specific treatments? Drugs? Therapies?
Well, there's ongoing research, which is hopeful, exploring things like cell therapies, gene therapy. The notes mention trials of certain drugs, often antioxidants like idebenone, but they also state that these haven't really shown significant benefits so far, according to this source.
Okay.
Other potential treatments being studied are listed things targeting iron overload like deferriprone, or trying to boost mitochondrial function or gene expression, but nothing definitive yet.
So the mainstay is really supportive care.
Exactly. That's where the focus lies. Things like physiotherapy are vital to maintain function and manage spasticity or weakness. Speech therapy for the dysarthria, and also for swallowing issues, which can become a problem.
Right.
Occupational therapy helps with adapting daily activities. Collaboration with schools and social services is important too.
And managing the other problems.
Yeah.
The heart, diabetes.
Yes. Managing the complications is huge. Cardiac problems are treated with standard medications for heart failure or arrhythmias. Orthopedic surgery might be needed for severe scoliosis or foot deformities. Even things like managing cold blue feet, peripheral cyanosis with simple exercises. Diabetes needs managing, usually with insulin. Bladder problems might need medication. Swallowing issues or dysphagia could require diet changes or even a feeding tube later on.
Anything else noted for management?
A couple of specific cautions. Being careful with certain anesthetics, like propofol, and special considerations for pregnancy, as there are increased risks like heart issues, blood clots, and preterm labor.
Okay. Looking down the road then, what's the long-term outlook? The prognosis?
It does vary between individuals, but the notes indicate it's typically a shortened lifespan. And the major factor limiting lifespan is usually those cardiac complications.
Do they give an average figure?
The average life expectancy is stated as around 40 to 50 years. Though, importantly, they add that progression isn't uniform, and some people do live into their 70s.
And what about mobility? Is wheelchair use inevitable?
The notes suggest loss of walking ability typically happens about 15 years after the diagnosis is made.
So to summarize the main complications that drive the prognosis and care.
You've got the progressive disability itself, leading to wheelchair reliance, the severe cardiac problems, heart failure, arrhythmias, the development of diabetes, and potential respiratory complications too. These are the big things that need constant monitoring and management.
Wow. Okay, this has been quite the deep dive. We've gone from a single gene defect, the GAA repeat in the frataxin gene,
Leading to low frataxinprotein, mitochondrial dysfunction, iron issues.
which then causes this whole constellation of problems, the ataxia, the sensory loss, the heart disease, diabetes, skeletal changes.
It really illustrates how one core molecular problem can ripple outwards and affect so many different body systems. Understanding that link between the frataxin, the mitochondria, and the energy needs of nerves and heart muscle really helps make sense of it all.
Right. And maybe here's a final thought for you, the listener, to chew on. We've seen how the lack of frataxin impacts mitochondria and iron, primarily hitting nerves. But how does that same core problem explain why the heart muscle specifically thickens in that hypertrophic cardiomyopathy, or why someone might develop diabetes?
It really speaks to the fundamental role of cellular energy and metabolism, doesn't it? how disrupting that can have such diverse consequences depending on the tissue.
Absolutely. So if you are revising this topic or just trying to get your head around complex conditions, digging into notes like these or using resources where they come from can be incredibly helpful.
Definitely. And the sources these notes seem based on mentioned sites like PathomSRA.com and FreeMSRA.com for more revision material.
Worth checking out. Well, that brings us to the end of this deep dive on Friedreich's ataxia. Thanks so much for joining us.
Thanks for listening. Keep digging. Keep learning.